So the next topic is to cover the topic of fetal brain malformation, and because I've covered a fair bit of this in the live scanning this morning, I might skip one or two slides as I go through, so we just make sure we maintain our time for Q&A. So the talk is divided into the following sections. I'm just going to give an introduction. I've mentioned very quickly the guidelines, and then the anomalies. I give a little bit more depth to these anomalies, which I briefly covered, including this. And then I'll say a few words about spina bifida, because that is extremely challenging, and there's lots to say about it. And then we'll talk about the cord plexus cyst, because I know that came up in Q&A this morning. So you say to me, Simon, what is the detection rate of structural brain malformation in the first trimester? I'll say to you, if you open any textbook of fetal brain malformation, of fetal neurology, the textbook is that thick. And you have all these long, lengthy lists of conditions, and you say, you're never going to pick those in the first trimester, and I say, I agree. But actually, while numerically, these are a very long list, and I've only included a fraction of them, the list is about 3 times that list. You'll never pick them up in the first trimester of pregnancy. They actually make up about 1/3 of central nervous system malformation. But this group that you always see are far more prevalent, and similarly with the group that sometimes. The answer is about 2/3 of major brain malformation can be detected in the first trimester of pregnancy. And that's why it's so important to have that systematic approach of looking, not just taking a sagittal section, looking at an intracranial translucency and then packing your bags and going home, but rather having a systematic approach as to what you do. Now you can choose to do that in a basic assessment, which is the basic guideline, because you really need to align yourself where you sit. Do you sit as a basic screening person, or are you doing the advanced screening? From the advanced screening, I've already mentioned this, and I simplified it by measuring these black spaces. Anterior border brainstem, posterior border brainstem, intracranial translucency, choroid lining the roof of the fourth ventricle, cisterna magna, nuchal translucency. A lot of lines and a lot of spaces. It requires a fair bit of training before you become familiar with all of those spaces. That's why I think it's so challenging as screening spina bifida for looking at these lines and spaces, because you've got to be doing a lot of scanning before you recognize something's wrong with those lines and spaces. Whereas the axial section of the brain, the beauty about it is everybody in this room knows how to do a BPD. Everybody knows how to do a lateral ventricular measurement. And therefore, I think combining the quad section of the brain with measuring the intracranial translucency is very valuable. And we published this back in 2023, the importance of doing this 4-quadrant assessment for these 2/3 of the anomalies, which you will identify by doing that quad analysis. Now, I know I spoke about ecografia, and I gave an example about how you could easily miss this diagnosis on sagittal imaging. And I think if you look at it, they're actually not just one type. And this is a series we reported back in 2018. There are different types and the sonographic appearances of acrania, and it all depends at what point you do the scan across from 8 weeks to 14 weeks of gestation, because there are different degrees of brain degradation. If you look at it, and I match these images which we reported on and sonographically walk you through them, the brain can appear bilobular, the brain can appear foreshortened, the brain can appear elongated, a little bit like Bart Simpson's. The brain can appear cystic. And I think for many of these cystic brains, I think they're actually a vascular event. I don't think they're failure of closure of their neural tube. And if they're not a vascular event, I think they're probably related to amniotic band. If you ever see the cystic acranias, you need to increase your gain. They can look like an encephalocele where the brain is hanging over the fetal face, or they can simply look like a completely irregular brain. I think once you see these images for once, just pass over them once, you begin to realize is that they, not just one type or one sonographic appearances of acrania. And then with Valdo Sepulveda, we reported on the Turkish turban sign, which is another sonographic appearances of acrania. But I will say, for acrania, when I talk about the 4 sections of the brain being abnormal, in a small proportion of babies, when you look at the fourth ventricle transverse diameter is increased. And these are a unique group of acrania, because when you see acrania like this, you see the big dilated fourth, and you know it's the fourth ventricle because you can see the echogenic bar, the C-shaped choroid bar. If you see it's dilated, you know it's likely that this acrania is due to a chromosome abnormality, most likely digonic triploidy, and if not that, trisomy 13 or trisomy 18, or indeed the microdeletions and duplications. So don't just simply run with a straightforward diagnosis of acrania. It could be, in fact, more than that. In fact, anytime I see that there's dilatation of the fourth ventricle, the next thing I look at is the baby's abdominal circumference, because if it's below the first centile, I know I'm probably looking at digynic triploidy. You say, Simon, what's the importance of that? Well, I think it's important in terms of counselling the patients, because if the neural tube defect is a sporadic event, you're talking about a significant risk of recurrence and putting the patient on folic acid. If you know it's a digynic triploidy, if you now trisomy 13 or 18, the risk of recurrence is much lower. I mentioned the point about how we make these diagnoses even earlier in pregnancy, and that's because the new world we are going into, as we are offering cell-free DNA as a better screening test than combined first trimester screening, we are going to be in a world where we are scanning and seeing these acranias much, much earlier in the pregnancy. Cephalocele, when you look at these, we reported on the series of 35 cases of cephaloceles over 10 years ago, and what we recognize that for most of these they are occipital. Again, with Valdo Sepulveda and others from Madrid and Russia, a multi-center study, over 70% of these are occipital. But the important you need to recognize is that these ones, the parietal, particularly these are associated with the amniotic band syndrome, and also you need to check for these as maybe associated with the disruptive syndromes, and that's why the importance of increasing your gain. And also about 10% of these would be related to Meckel-Gruber. So when you see an encephalocele, your next step is to examine the kidneys. So I want to go through these examples with you, with the 18, Meckel-Gruber, disruptive syndromes, and then I'm going to talk about these extremely challenging groups, the cases where they evolve and resolve during pregnancy, which is important to know about. Now, I think everybody going to work tomorrow in the morning will recognize when you go to your four quadrant, section number 3 is your aqueduct of Sylvius, which is this box of fluid here, is actually sitting outside the occiput. Here's your defect. So that's a mid-brain herniation through an occipital defect. When you go to a vaginal scan, it's much, much easier to see it. And when you look at a vaginal scan, you see this complex solid cystic mass arising from the occiput. That is just a straightforward encephalocele. But there are others which have a different appearances. And then when I look at this encephalocele, by the way, it's a patient understands this image far more than anything you will show them on 2D. But when you look and see an encephalocele, so this is a fetus where you do a crown rump length, 13 weeks. You see the nuchal translucency is thin. And looking at the posterior occipital region, you see there's a defect in the posterior skull. You'll recognize that if you don't see it on sagittal, you will certainly pick it up on a 4-section axial assessment. When you look down at the kidneys, you see that the kidneys are cystic, and when you look at the baby's feet, you see it's got polydactyly. So this is Meckel-Gruber syndrome. And in a sense, when looking at Meckel-Gruber syndrome, you're looking at doing exome sequencing. You can do a targeted sequencing, but as a general rule, we're moving straight to exome sequencing. And this becomes important in terms of how you counsel patients. So always bear in the back of your mind, based on our series, that there is that 10% of them will be actually related to a monogenic single gene disorder. And I think that's important. You may turn around and make a diagnosis tomorrow morning and say, that's an encephalocele, counsel the patient, and then go on accordingly. But actually, if you turn up the gain, you see there's multiple bands extending to this baby's head. In fact, this is an encephalocele related to amniotic band. And how I counsel this patient is different to those who just have an isolated encephalocele in the first case I presented. Because the chances of this baby having this again are extremely low, because amniotic band syndrome is not a recurrent condition, or a condition that recurs. Now you examine this brain, you say, Simon, I look at this 4th segment, and I remember you telling me about the first segment of the brain. You take a transverse section, you see the lateral ventricles, and inside you see the choroids. And I said the choroids are more than 50% lateral ventricle, but where is the fluid in this baby? When you're looking at the choroids and you're looking at the brain, you say, Simon, my gosh, those choroids look so big in comparison to the calvarium. The answer is because there is no fluid in this baby's lateral ventricles. And then you ask the question, why is no fluid in the lateral ventricles? Does the baby have spina bifida? As you do so, you then go back to the midbrain and the brainstem, and you see, in fact, that's herniating through the occipital bone. Then you say, why? Then you turn around in the sagittal section, you see the fetal head is hyperextended. This is another baby who's got a amniotic band syndrome. And that distortion and extension of the head is the clue that there's something going on here. Again, it's likely to be an encephalocele with amniotic band syndrome, a very low risk of recurrence in future pregnancies. Then there's the next group, which is really challenging. And in a sense, it's almost a point where I regret sometimes that I made the diagnosis early in the pregnancy, or I cancelled the patients early in the pregnancy. I've certainly learnt over the years from these, because when I look at this and I see this scan in this patient at 11 weeks of gestation, and I see that the aqueductus sylvius is sitting outside in this, outside what I think is the amniotic sac. It's actually covered by the occipital membrane, and I'm coming up with a confident diagnosis. This baby's got an encephalocele herniation of brain with a meningeal sac. But this patient came back to me, chorion biopsy was negative, came back to me at the mid-trimester, had a completely normal scan findings, and I'm jumping to show you straight away is what the MRI looked like with a completely normal posterior cranial fossa at 22 weeks of gestation. And all that we could see here was the straight sinus, which is extended into it. And this is a typical finding of an atretic cephalocele, which carries a very good prognosis. And this baby is now delivered and is doing well. But that's not how I saw things when I first saw her. On the flip side of the coin, I saw this patient at 10 weeks of gestation. I said, listen, in my mind, I was thinking, I'm not too worried about this. This is a meningocele. All the brain landmarks look fine. The brainstem, intracranial translucency, cisterna magna. This is nothing to worry about. But 2 weeks later, 1/3 of the brain had herniated through that defect. So this is an example of an encephalocele that had evolved. So I'll show you one that had resolved and one that had evolved during the first trimester of pregnancy. This makes me extremely cautious about how I counsel patients with encephaloceles in the first trimester. Again, I see neural elements inside a cystic lesion outside this baby's head. I ask myself, what do the four segments look like? I look at the aqueductus sylvius. I look at the cerebral fourth ventricle. I look at the choroid bar. It's all completely normal. So I'm beginning to think this baby doesn't really have too much going on. It's probably an epidermoid cyst, a cyst in the skull. But when I bring the patient back at 18 weeks of gestation, she's got severe bilateral ventricular dilatation. So there's an underlying CNS pathology. They're extremely challenging. So in the next patient, when you see something like that, you say, tie your hands behind the back and first do no harm. Because when you look at this baby, another example, with a normal four-quadrant assessment with exactly the same appearances, which was completely normal at 16 weeks of gestation, and this is a baby who had a scalp epidermoid cyst. So my word of caution to you is just be very careful about making a call of encephaloceles in the first trimester of pregnancy and how you counsel them. And the other group is the ones who are truly meningoceles. When you see this meningeal sac, and in this baby with the meningeal sac, brainstem, IT, and cisterna magna. You have three spaces, descending aorta, descending order of size, and normal. And don't mistake it for this. This looks like a meningeal sac, but it's actually outside the amniotic membrane. The yolk sac is not inside the amniotic sac, it's outside the amniotic sac. It just happens to be juxtaposed to the fetal head. And this is another baby which I saw very recently, which looks like it has a large meningocele, but in fact this is a baby with a hydrops fetalis with simply scalp fluid, mimicking a cephalocele. So if I look at all those conditions and you say, Simon, what is the easiest diagnosis to make in the first trimester of pregnancy? It's holoprosencephaly. So why do I say that? Well, because it has 3 sonographic markers which you can rely on, not 25 sonographic markers like spina bifida or 20 markers like spina bifida. And it's a condition in a sense that carries a terrible prognosis. If you look at alobar or holoprosencephaly, which is a condition where there's failure of cleavage of the brain into 2 separate hemispheres. And that failure of cleavage comes in 3 forms. The ones we see in the first trimester of pregnancy is the alobar and the semilobar. We cannot pick up the subtle failure of cleavage, lobar. For those with the alobar holoprosencephaly, 50% of these die within the first 4 months of life. It's a terrible condition. The 3 sonographic markers, however, that allow us to make a diagnosis: an absence of a falx, loss of the butterfly sign. When we talked about the butterfly sign, that's the first section where you show the midline falx and the 2 choroids on either side. Valdo Sepulveda described that as looking like a butterfly. So that's lost, and there's a single anterior monoventricle. We also reported across a large series back in 2014, the same group, that the BPD in these babies is below the 10th centile. In fact, if you look at it, if you do a BPD tomorrow morning when you go to work and find that you've got a BPD that's below the 5th centile, for example, you should trigger a thought that the baby could not have only holoprosencephaly, it could have an encephalocele, and it's also a marker of open spina bifida. So that's another reason why we do these biometric assessments. It's not for dating the pregnancy, it's using them as markers for underlying structural malformation. I don't think anybody in the room would miss this diagnosis because there's no midline falx. You see a single anterior monoventricle, and when you look at the choroids, there's no butterfly choroid on each side, but you have the choroids going across the midline. It's a sort of an unmistakable diagnosis. And that's why, in a sense, if you ask me about making diagnosis very early in the pregnancy, this is a condition where I feel I can be confident about making very early. So let's look at it, put it to the test and do a 4-quad. Well, there's your choroids, absence of the falx, and a single anterior monoventricle. You then go looking to see if there's a cavum velum interpositum, which there isn't. You look at the aqueduct of Sylvius and the distance between the occipital bone, it's okay. If it wasn't, I would think of coexistent open spina bifida, which you can get with holoprosencephaly. But importantly, I look here, the 4th ventricle, because I know the 4th ventricle is dilated in the setting of trisomy 13 and trisomy 18. So it'll tell me this is likely to be holoprosencephaly related to aneuploidy. And I'll just skip these, just by a little bit of time. So if we next move to the cerebral 4th ventricle, and I'm going to show you a 4-segment analysis and ask you which do you think is abnormal. This is case A on the left, and this is case B on the right. You have the midline falx, lateral ventricles, the choroids, the cavum velum, the aqueduct, the 4th ventricle, and the choroid. So this looks okay, this looks okay, aqueduct looks okay, but then you see this big dilated 4th ventricle. So compare this 4th ventricle here to this 4th ventricle here. The 4th ventricle is, for some reason in the history of prenatal ultrasound, has received very little attention. It's received lots of attention from the point of view of spina bifida detection because your IT is small. But for me, the highest proportion of when I look at it, of CNS anomalies I have over 30 years of collecting cases, is a dilated cerebral 4th ventricle. And it's a very, very powerful marker when I see this big area of fluid lined by the hyperechogenic choroid lining the roof. This baby also has a hypoplastic left heart. And if you in fact look at it, 53% of babies with trisomy 18 will have a dilated cerebral 4th ventricle. And that's why it's such a powerful marker. This is a baby who's got bilateral pleural effusions, a fetal tachycardia, and I spoke today about the power of turning on color and dropping an M-mode line. Why is that so cool? Because it actually shows you the individual complexes so much easier to read, because M-mode can be hard for those who are junior in your training to work out where do I place my caliper. When you're doing it, you doing it with color with M-mode in pregnancy. Long bones are short, and here you have a big dilated 4th ventricle. 80% of babies with trisomy 13 will present with a dilated 4th. And similarly, we continue on for more examples, big dilated 4th, a baby with a cystic hygroma. Again, monosomy X also presenting. But I think looking at this 4th ventricle is so much easier to see than recognizing on a sagittal section that the intracranial translucency is increased. You go to work tomorrow morning, you scan this baby and you take a crown rump length. And when you do so, you look at the profile and you say, wow, that baby's head looks big. And you say, well, not only does that baby's head look big, you see that your intracranial translucency is increased. You say to yourself, what's going on? Well, in fact, the head is normal. It's actually the abdominal circumference is tiny. It's got a slim abdomen with a big dilated 4th ventricle, which is a classic appearance of digonic triploidy. And if you look at it, depending on the series you read, this is the more conservative series, 83%. If you look at the series from the Israeli group, that's close to 100% of digonic triploidy. You say, Simon, what's the big deal about that? You're going to pick that up on NIPT. And the answer is no, you're not, unless you're using a SNP-based platform. So you need to be careful about it. If you're just using your standard platform for NIPT, you are not going to pick up digonic triploidy. So that's why it's important. You may also, if you do your chorion biopsy and it comes back normal, you're then faced with a patient where you see that the fourth ventricle is dilated, and you bring her back at 20 weeks and you see all the features of a Blake's pouch cyst without pouching, and it fenestrates typically in the third trimester with a plumb normal vermis. That's a great outcome for that patient. She was delighted with the outcome. I raised the point of concern with her when she was 12 weeks because I saw a big fourth ventricle. The chorion biopsy told me the chromosomes were normal. This patient, a similar story, a big dilated fourth ventricle, but when I saw her back at 20 weeks, sadly, it was a very different story. No vermis with wide splaying of the cerebellar hemispheres in a baby with Dandy-Walker malformation. Now you ask me the question, Simon, roll back in time, and why weren't you able to tell either of these patients as to which they were going to have? Really, the answer to that question is I don't think we have enough data, but there is some early data that suggests that if the aqueduct of Sylvius is obliterated or absent, that this is going to be a Dandy-Walker malformation. Whereas if the aqueduct of Sylvius is normal or increased in size and the fourth ventricle is dilated in a baby with normal chromosomes, that this is going to be a baby with Blake's pouch. And I think the evidence will come in time supporting that in counseling patients going forward. So next move to next section is I'll say just a few words, just check my time, 21, I have another 5 minutes. I'll just say a few words about spina bifida. Spina bifida is singularly one of the most challenging diagnoses in the first trimester of pregnancy. Let me delete that figure. About 30% of babies with spina bifida you will identify by looking at the spine. Remember, the spine, I said, in about 10% of babies are not able to examine because of the position it's in the first trimester. We don't bring them back. For the greater part, we rely on looking at the brain for markers for spina bifida in the first trimester. So you say to me, Simon, why don't you look at the banana cerebellum and the lemon-shaped head? Because that's what you did the second trimester. Because the answer to that is looking at the posterior cranial fossa is not that good in the first trimester. You need to look at the midbrain and the brainstem. And I'll bring you straight to the bottom line on it. This shows you the fourth section of the brain that I spoke down here, where you see the box of fluid, which is your aqueduct of Sylvius, your cerebral peduncles, and your thalmi. Everybody in the room knows how to take a BPD at this section. When you look at the BPD in a baby at 13 weeks, that's what it looks like. It's normal. But this is what happens in spina bifida. It gets displaced posteriorly. And I think that's why I like it, because in a sense everybody knows what a BPD looks like, and this is what happens in spina bifida. You get posterior and inferior displacement on sagittal imaging, and instead of having 3 black spaces, you will end up with 1 or 2 black spaces where the second one is small. That's showing you what happens in spina bifida. Now let's put it to the test. This is a baby with spina bifida 12 weeks and 5 days. And as you look across, the same baby here on this one, if you look at this 3 black spaces, to the trained eye, you will turn around and say that that brainstem is big, and I'm only seeing 2 black spaces. But it requires so much training to get to the point where you recognize that. In the same baby, when you look at the BPD, the aqueduct of Sylvius should be here. This should be your thalmi, and this is your midline falx. But instead, it's sitting pushed right back up against the occipital bone. It's a very straightforward diagnosis. I'm not saying that you should choose one over the other, but you need to combine both of them. Another baby, dilated, enlarged brainstem, and your black spaces here are out of order in proportion. But look at the axial imaging. You can see that whole brainstem is displaced posteriorly. I finish up on spina bifida by showing you 12 examples of spina bifida as you scroll through all of these. And for those of you who are experienced in your field will recognize each one of these as you look at them, because your black spaces of 3, 2, 1 brainstem, intracranial translucency, and cisterna magna in all of these is abnormal. But it just took me so long to learn that. Whereas when I look at these cases here, at an instant when I look at all of these cases on taking a BPD measurement, my sonographer staff recognized that there was something wrong about the brain. And you know why? Because they all measure routinely the distance between the aqueduct of Sylvius and the occipital bone for every scan that they do. and that's 12 cases of spina bifida and another 12 cases of spina bifida, all demonstrating an abnormal appearance when you go to take a BPD with the shift of the midbrain to the occipital bone. If you combine both, you will reach a point where you will detect the majority of babies with spina bifida. I'll finish up with my last slides on ventriculomegaly. You need to be careful about ventriculomegaly. You cannot take a measurement of the lateral ventricles at 12 to 13 weeks of gestation. It serves no value. In detecting ventriculomegaly in the first trimester of pregnancy, what you need to do is to measure the area of the choroid and to reference that to the area of the lateral ventricles. In practice, though, to be honest with you, none of us really do that. We make a subjective call, and we say, when I look at the choroids here, I see that the choroids occupy less than 50% of the lateral ventricles. I see there is a disproportionate amount of fluid. And for many of these, they will have something else going on. In this case, a baby's also got dilatation of the foramen of Monroe, dilatation of the third ventricle. This is a classic case of aqueduct stenosis related more than likely to L1 CAM mutation. Again, making that diagnosis of 12-1 and getting an L1 CAM mutation result is so important, getting it early in the pregnancy. And you may find scenarios of ventricular dilatation other than that. You may also see it in the trisomies, but for many of these, this baby, bilateral hydrothoraces, the choroids are less than 50% of the lateral ventricle in a baby with trisomy 21. So lastly, I'll just say very quickly, because I know somebody mentioned about cord plexus cysts, and I would say be very careful about cord plexus cysts. They're mostly benign the first trimester. Just make sure there are no markers to support trisomy 18. But here's several examples of these really funny, strange-looking mottled choroids. I don't mention anything to the patient if everything else in the baby's normal, even if I'm seeing these really striking dilatation of the choroids. And some of them can look like brain tumors. This is a case with a baby where the sonographer came out and said, Simon, I think the baby's got a brain tumor. But again, you go through your process of your 4-quadrant analysis and you realize that all this is just very striking choroids in the first trimester. So please be very careful about these. I'll finish up. The take-home message I have is that if you think of one organ system that's got the highest detection rate the first trimester, it has to be the central nervous system along with the cardiac. I think if you go to work tomorrow morning and you have a systematic approach of a very simple thing of looking at these 4 sections and knowing what those landmarks represent, and followed by knowing what each of these landmarks represent, you may not measure everything, but at least consider, if you want to do it for spina bifida screening, this is the most powerful measurement. The brainstem to the occipital bone distance, not the intracranial translucency. In fact, only 20% of babies with spina bifida will have an absent intracranial translucency. So for spina bifida detection, that's the measurement I take. But I think to simplify things, just look for 3 black spaces in descending order. And if it's not there, then question that there's a problem. Thank you very much for your attention.